This podcast is sponsored by Blue Room. When lives are on the line, every second counts. Every movement, every decision, every breath. That's why Blue Room simulations exist. The world's most advanced mixed reality training simulator. Designed to put you under real pressure in real environments without the real world risk. So no bulky controllers, no gimmicks, just your hands, your kit, and a level of immersion that makes you feel like you step straight into the mission. One moment you're in the cockpit of a Black Hawk, the next in the KSO combat zone, or on the side of a cliff, training as if it's happening right now. So born in Australia, trusted across 5 continents, Blue Room is redefining readiness for military, medical, and frontline professionals worldwide. This isn't the future of training, this is training transformed. Step inside Blue Room Simulator, visit blueroomxr.com and request your demo today, or see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today, we're diving into one of the most challenging scenarios any EMS provider faces, that of pediatric cardiac arrest. So the figures are challenging, with only 4.9% survival rate for infants and neurologically intact survival rates as low as between 1 to 4% nationally. So these calls have long been considered to have poor outcomes. So what if I told you that one fire department completely rewrote the playbook on pediatric cardiac arrest and achieved neurological intact survival rates of up to 46%? So what if they did that by breaking conventional rules, staying on scene longer rather than shorter? So today we're joined by the Medical Director of Polk County Fire Rescue in Florida, Paul Banerjee. He's going to really speak to really how they've transformed pediatric cardiac arrest outcome through changing protocols that pretty much has changed everything we thought we knew about pre-hospital resuscitation. From their no-go dispatch system to permissive hypercarbia post-intubation, from mechanical CPR to aggressive on-scene airway management, Polk County have really proven that with the right approach, we can dramatically improve outcomes in this patient cohort. Welcome to the podcast, Paul.
Thanks for having me, and thanks so much for giving us the opportunity to share the great things we're doing here.
I'm actually going to start, Paul, by really just getting you to just fundamentally walk us through the historic sobering statistics, really, of pediatric out-of-hospital cardiac arrest survival rates, and what was the motivation, really, to flip the narrative and completely rethink your approach.
So basically, we know that survival rates are pretty dismal worldwide, especially where we were. I joined a new agency in 2014, and you kind of like start a new place and go, what's the deep dive? Where are we? When it came to pediatric arrest, we killed everybody. So for the last 2 years prior to my arrival, we had ROSC rates of 10, 11%, which is nice, except everybody died. So we did everything what everybody else did, and we kind of accepted the results that were. So I thought, well, no matter what I did, it couldn't be any worse than 0. So everything I did or anything I changed, I couldn't get lower than 0% survival. So it was kind of a progressive change and approach to how I can change and modify the approach to pediatric arrest.
So just looking at that and rewriting the playbook, could you maybe speak to some of the conventional wisdom you challenged? And I guess in a way, and just quite honestly, Paul, was there any resistance from the team to some of those, challenging some of those fundamental assumptions?
Well, I think people do challenge what is varying of the norm, but when your results are 0, I mean, everybody dies. It's really hard to say, well, I'm gonna die on this mountain because this is the way it is. I go, we're doing it the way it is, and everybody dying. So let's try a different approach. And if I'm wrong, we'll change and go back to doing it the way we were before.
Yeah, absolutely. Absolutely. And something that was really been a cornerstone of advanced practice, certainly within the UK and critical care is, as you were saying, staying on scene longer, but actually, addressing what needs to be addressed. And this philosophy of really rewriting the narrative on addressing fundamental hypoxia, the quality of chest compressions, maybe initially the approach to pharmacology and drug administration. Could I get you to really, just walk us through staying on scene longer and addressing some of these, we say the basics, but actually the essentials?
Yeah, I think when we look at it with adults, we don't think twice. We know exactly what to do. We know the doses. if we find someone 70-year-old who is unresponsive on a couch, we don't take him on a stretcher, walk him to the ambulance, start looking up medications, and then start initiating therapy, which is what we did with kids because we didn't know what we were doing. We were not comfortable, right? So how about if we treated kids like we did adults? Why don't we just, this is what you do for adults, this is just baby adults. So let's understand the fundamentals of what meds are we using, what doses do we need, what do we do on scene, same thing we would do with adults, same thing we do with kids. Let's try that approach. And that was just a fundamental, just a system approach. So we used the tape method, and after analyzing the tape method, we found a lot of irregularities of wrong dosing. So we chose a different system to approach it, which case basically the reason people stress about pediatrics is the math. So I don't want to give too much medicine because I don't want to harm the kid. Well, the kid's already dead. You can't really harm anybody more because they're dead. So is there a more scientific or mental approach? Can we change from a system two thinking, which is having to calculate answers versus reflexively knowing the answers? And so I found a method that became system one thinking that would be doing the same thing as you would do with adults, and variable different things that we approached on scene physiologically that would be different than what everybody else is doing, but it would kind of, you have a medication and then there's a side effect to the medication. So then we have the symptoms like, why do I have this? Well, it's because of the medicine you gave. So how do I compensate for the medicine that I gave? Oh, this is what I would do. And obviously it's not going to be overly complicated because you're basically dealing with 20-year-old young men and women who are just out of high school and maybe in a college who are approaching this arrest. And the more complicated you make it, the more mistakes people would make. So how can I make it simple, straightforward, and at the same time, it's more reflex thinking, just like you would with adults. And I think just changing that narrative helped.
Yeah, indeed, absolutely. So let's just talk about the playbook which you rewrote. So you really brought forward a lot of things. You really brought forward epinephrine or indeed adrenaline administration times from 26 minutes down to 5.6 minutes. So let's just talk about epinephrine, but also about airway management and consistently good, methodical CPR. But could I get to speak to, but just take us through the bundle of care that you changed?
So I think first thing is you work somebody on scene where they are. And a lot of it is, you have the pit crew approach, which they do in adults. One person's in charge of the airway, one person's in charge of compressions, one person's in charge of the medications, one person's controlling the time. With the fire department, you have multiple system response, which if you look at the pediatric arrest algorithm, it was an alpha response, which means you send the least amount of resources. With an echo response, you're sending the whole cavalry. Everyone's coming. So let's send everybody because we need people. A lot of it is controlling the scene. So you have parents who are distraught, who are unable to comprehend what's going on. Their little baby's dying. Well, how do I get someone to kind of educate? This is what we're doing. This is why we're doing it. We're not moving them to the ambulance. We're not taking them to the hospital. Because if you really know, hospitals do a terrible job when it comes to pediatric arrest. If we don't have a pulse back by the time they get to the hospital, it's a 99% chance that child will die. So the best chance you have is you have basically 10 to 12 minutes before you get ischemic brain death for a child. If you wait for therapy and resuscitation to get to the hospital, guess what will happen? The child will die. Or they'll be brain dead and they'll be good organ donors, which will help somebody else, but isn't too helpful for the family that sees their child in front of them. So organizing the scene, changing dispatch matrix. We had the system that we used that is a number-based system. It's called the hand-heavy system. Based on the age, there is a weight given to that child. That weight is basically an ideal body weight, similar, and the medications are calculated based on ideal body weight. It's not exact, it's approximation. But if you look at the tape, there are kind of a lot of variance into what the approximation is. So what we did was we got these are the numbers if you're, and a simple thing is the hand heavy is 5, right? So you have thumb, which is 1, 3, 5, 7, 9 years old. They're 10 kilograms, 15 kilograms, 20 kilograms, 30 kilograms, 35 kilograms. If you know the age of the child, say the child is 3. So you have 3, that's 15 kilograms. I've already the doses that I need, the quantity that I need. So when they call dispatch, they said it's a 3-year-old drowning. And just as a side note, we are the #1 drowning pediatric death area in the world, probably, because we're right near Disney, and a lot of families come over, don't have pools, don't know pool etiquette, don't know pool safety, and that's why a lot of these kids drown. So if we know what age they are, it's a 3-year-old who's drowning or doing resuscitation, the medications can all be drawn up by the paramedics. By the time they get there, everyone already has an assigned role. The one person is immediately going to get the airway. You can do compressions, get the airway. The meds are pushed. There's no thought required. The same as you would with an adult. And so that was the beauty of the simplification of working them on scene, getting the airway early. We also had a PEA bundle, and you know the survivability of PEA is less than 5%. So the bundle of care was, we have Narcan, we have your epinephrine, we have the bicarb, we have calcium, we have fluids. So basically, of the H's and T's, which they're 12, it hits 9 of them. So instead of trying to be scientific, we just kind of like shotgun approach that rhythm. How do I treat it? VFib, VTAC, we doubled the initial doses. So instead of 2 milligrams per kilogram, we do 4. We would do 8 the next one, and if we have to, double sequential. So it's basically a more aggressive approach. Now, thankfully, we've got a lot of kids back. So once they got them back, so we've given all these medications that they are great because they stimulate the heart. The problem with the side effect is they cause vasoconstriction. So as your brain is getting the brain is already ischemic because it's been down without oxygen for a while. Now it's even more constricted because the medications you've given. But one thing we do better than the hospitals is manage and regulate end-tidal CO2. And end-tidal CO2 is a sign of resuscitation. It's how well the cell's doing. It's a sign of metabolism of the cell, how alive you are. It's a waste product measuring. That means we're living. If we can control the amount of end-tidal CO2 that's released by the cell, we can regulate the peripheral nervous system, the peripheral vascular system. So it also causes renal artery vasoconstriction. It causes heart rate stimulation. It also causes cerebral artery vasodilation if you control the CO2 levels. So what we did was we had it, normally people do between 35 and 45 for end-tidal CO2, but that's for normal people in normal systems. This person's ischemic with a medication that's going to cause vasoconstriction. So let me overcompensate for that, raise the CO2 higher, which will cause the arterioles to dilate more. So we had the end-tidal CO2 between 45 and 55. Obviously, we're working them on scene. We also have an end goal of blood pressure based on age. So based on what age you are, you want to make sure that the brain is being perfused. So that involves saline and involves push dose pressors to get that map where it needs to be so the brain is being perfused. So basically, it was a whole bundle of care. It's not one thing that we did, and we found amazing results just by doing that.
Yeah, listen, that's fantastic. And as you said, what the counterplay and counterbalance there is permissive hypercarbia, because like you said, with the push dose pressors, there's a lot of squeeze and a lot of vasoconstriction, so it's countering that vasoconstriction, which is fantastic. But as you were saying as well, just really regulating the EtCO2 so that there is a semblance of balance with slight permissive hypercarbia. Could I get you to speak to mechanical CPR for patients 4 years and older, just to really achieve that compression fraction of greater than 80%? And indeed, what were you seeing through that change, like you said, as a bundle, really? And indeed, was there kind of a good adoption to that protocol?
Well, I don't think there's 2 things paramedics do not like: change and the way it is. So no matter what you do, they're never going to be happy. So how do I find a way to say, well, we use mechanical CPR for an adult. If the child's chest fits in the diameter of this Lucas device that we have, you can get consistent compressions at a rate of over 100, 120 per minute. And then you can focus on the things that matter, like rhythm analysis, airway analysis, medication dosing, controlling the scene, and getting the environment to be optimal for resuscitation outcomes. So if they fit in the device, you can use the device. Based on the diameter of the Lucas device, I think it's 17 inches that you could have the child in. So if you look at this, the normal diameter of a child based on just, again, these are not exact, but these are based on average parameters. A 4-year-old would have approximately 17-inch diameter. We'd be able to put that child in there. And, when you have compressions on a child or someone really old, you're not as effective as you are because you're afraid of hurting. This way, this device is doing it for you. And there's also a negative recoil, which you can't do as well when you're doing manual compressions because you get tired. And all the studies have shown the mechanical versus regular, there's not really a whole lot of difference. But what it does is when you're transporting it, scene safety, that's one less thing you have to worry about. Again, it's an extra pair of hands that you can focus on how the patient's doing.
Yeah, indeed, indeed, and as you said, it's really multifactorial. So that is one intervention amongst many, which is really contributing to the significant increase in. But in ROSC, as you were saying as well, Paul, it's not just ROSC, it's neurologically intact survival, which is crucial as well. So, the two fundamental attributes are intracardiac arrest changes, which you've made, and then post cardiac arrest changes, post ROSC care, which is, as you were saying, permissive hypercarbia, but still within parameters, and indeed getting the map under control. And then, but to your wider points, let's just speak about some of the system-wide changes. So let's just talk about this no-go approach, and indeed community CPR, because again, it's multifactorial and it's what happens ahead of time before the providers arrive. Could you get you to speak to the no-go and indeed the community CPR?
Yeah, I think the surprising thing is that a lot of people will see a cardiac arrest and just kind of like not feel comfortable doing anything. And there was a study that showed that when they were actually bystander CPR involved, the neurologic survival was 2.5 times higher. Now, the no-go is a lot of dispatches, they ask questions and they ask questions and they ask questions. And Navigator is a good tool, except that there are sometimes too many questions to the point where it kind of paralyzes by analysis what someone's going to respond with. So with the no-go is, are they breathing? No. Can you arouse them? No. Just start compressions. So we're giving them a chance to, like, are they drunk? Obviously, are they intoxicated? Are they on medication that's caused them to be sedated? If you start compressions on someone and they're unresponsive, they're not going to wake up. Or if they are on medications or asleep, they will wake up. So either way, you've done a test. And a lot of what we do is not exact science. What we try to do is clinically triage mentally which way we go with a situation. So instead of trying to like, well, am I listening to breath sounds? I'm not quite sure. Are they responding? I'm not quite sure. Is this how he is? I'm not quite sure. And so what happens is you're asking so many questions and you let time tick by. So instead of that, 2 simple questions. Are they breathing? Are they moving? No, just start compressions. And if they're alive, they will just push your hands off their chest. And that's a good response as well.
Yeah, indeed, indeed. And, like you said, it's adoption, and it's in community engagement ahead of time, just with community-led CPR programs that to increase engagement and indeed education. But could I get a tip? So you've spoken to it already, but I firmly believe in this, having practiced it certainly in the UK, is this pit crew concept where no matter what the resuscitation looks like, pediatric or adults, the suction unit is at the left-hand side, the defibrillator is also at the left, the CPR is on the right, but there's an airway person, a person doing chest compressions, there's someone drawing up drugs or getting IV access. But with that system approach, it allows that formula to work and almost smooths out any of those changes, and it makes it less abrupt because everyone's got a role, and then the CPR can change until the mechanical CPR comes in. Could I get you to really just really unpack the advantage of the pit crew concept?
Yeah, I think the pit crew concept works because we now have an assignment. these are very chaotic, emotionally charged situations. Nobody wants to see a young child die. But if you know your only job is my job is to get the airway and I ventilate. Now, the ventilatory rate is another thing we adjusted as well, because normally AHA had 1 in 6 breaths a minute. We've done it to 1 in 10 breaths a minute. The reason we did the end tidal CO2 to be higher is it mentally slows down the paramedic. Because what happens is once you've intubated that child, you want to like your adrenaline flows and you just bag, 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 bag. Well, what you're doing is blowing off all the CO2. CO2 is a marker of survival. You're lowering the chance of survival. So by slowing the breath down, taking 2 deep breaths, expanding the alveoli, increasing perfusion, decreasing introthoracic pressure, by doing those things itself, you're going to increase coronary artery perfusion pressures. By hyperventilating, and this is all airway control, right? By hyperventilating, you're going to increase thoracic pressure, intrathoracic pressure, decrease coronary filling pressures, and the person's not going to probably make it. With this controlled approach of the airway, and then they have to be aware of the end tidal CO2, aware of the airway. Initially, when you do the intubation, you want to do, first of all, is 3 minutes of airway management, which means that we do DAI, not RSI. RSI is rapid sequence intubation, which you're doing paralytics, you're doing an induction agent, and you're going to do a sedative. What we do is we do an induction agent and a sedative. So instead of succinylcholine added, they're probably unresponsive and not breathing, don't really need a paralytic. So we would give ketamine based on blood pressure or etomidate if it's not trauma related. So you have a mental triage of which one you want to use based on blood pressure and mechanism of injury. And obviously Versed, any kind of benzo that you have available to help sedate that patient. But once you have that, we want to make sure that you bag them at 93% for 3 minutes. The reason is the 3 minute time is important because you denitrogenate the oxygen in the system. So if you will struggle with an intubation, and this is more so for adults than children, but if you do struggle with an intubation, you have a little more time to see if they're drowning, they have copious vomiting or pool fluid in their lungs or in their throat that you have to suction and clean to prevent them desaturating. So you're giving them 100% high flow oxygen, kind of like we did with COVID. Once we get that 93% for 3 minutes, then we attempt intubation. You get 1 shot of intubation or a supraglottic airway. And most people in this kind of crisis want to guarantee the airway, so they go to supraglottic airway. And once that is done, that's his job. He's got the supraglottic airway. His job is to bag once every 10 seconds after 2 deep breaths, regulate that end tidal CO2 between 45 and 55, and that's his only job, which is actually complicated in itself.
Yeah, absolutely, absolutely, and to not overcomplicate that, like you said, it's focusing on one task and one task only, which is fantastic. One of the things we realized actually, certainly within the UK, both from rescuer data and anecdotal experience, but also from maybe initial first aid or aid rendered into pediatrics, was aggressive bag valve mask ventilation. What this would do is hyperventilate and push air into the stomach, which would as the stomach inflated, it would splint the inferior vena cava and actually prevent ROSC, return of circulation. So what we started to see is a lot of return of circulation post. So we would place a nasogastric tube through into and decompress the stomach, get the air out, and there was a lot of return of circulation beyond after the air had been released from the stomach, just because that was really acting as a splint against the inferior vena cava and that return of circulation. Because to your point, I think partly the issue is on scene, there's a lot of endogenous catecholamine, so your homemade adrenaline, your homemade epinephrine, can take over sometimes, and rescuers can quite aggressively bag valve mask pediatrics to the point where they are, to your point, overinflating, and that air is going somewhere. It's going into the stomach rather than into the lungs, and actually that is actually working against return of circulation. Have you seen that in the field within Polk County?
Well, this was again before we did it, and I'm assuming we followed what everybody else did. But in addition to compressing the vena cava, you're raising the diaphragm, which again, you're increasing intrathoracic pressure, which causes you to decrease filling pressures. So you're kind of working against everything you do. And we do have an NG tube that we put down with the eye gel that again is to help decompensate, but you can control a lot of that side effect by controlling ventilation rate, controlling entitled CO2. That I think the adrenaline takes over and people think more is better, and it's not.
So just looking at, as you said, it's a system approach and there's no magic bullet. Could I get you to speak to, so, from 0% survival rates in 2012 and 2013 to 46% survival rates by 2019. I mean, that's an insane change, actually. Could I get you to speak to really, in a way, the most impactful changes you were seeing in staff? I mean, one of the emotional changes is seeing more survivors and seeing families of survivors. So this must be working, because not only a ROSC but a neurological intact survival rates increasing, but you're getting more survivors come back to Polk County and visiting the paramedics, visiting the providers, which in itself is encouraging. But could I get you to speak to really, yeah, just the fruition of these impactful changes and what you were seeing in the crews?
I think a lot of what you do in life is if you believe you can or you can't. When you see that that everybody dies, that when you do, you're like, well, it's not gonna work anyway. So paramedics are very, very thin people to make them 100% believe in something or not. So now I'm at a stage where I'm so proud that the crews are upset if they don't get a ROSC or a survival, if the patient does not go home. That is a whole mental change, seeing that, hey, everything I do works. And it's worked before. It's worked for me like 30% of the time, which is 6 times higher than national average, probably even higher in the world. In the world, it's probably less than that, because in Europe and USA, it's probably much higher than it is in Asia or Africa, right? So you have this kind of expectation that you're not going to die on my watch, and I'm going to do whatever I can to get you. I've done this before. I'm good at this. It's kind of like you are with adults. You're not going to die on my watch. I'm going to get you. And when you do, you're like, well, what could I have done different, right? So then you actually auto-regulate yourself and go, what could I have done different? So just that whole expectation change is a life changer, a game changer for the people.
Yeah, indeed, indeed. Could I get you to speak to really so if I'm correct in thinking, you assign, when you have the manpower, you assign someone to the family member just to really guide the family member through in non-medical phraseology or words, essentially just what's happening. So you break it down for them, get them to kind of, well, allow them in to see the resuscitation, but really support them through the whole emotive process. Could I get you to sort of unpack any feedback you've received from that?
I think the family members are obviously their most important thing that's dead. Um, what are these guys doing? Why aren't they rushing to the hospital? That's where they're going to live. Changing that mindset, going, this is what we're doing right now. We have to get the compression target to get his heart moving before we actually can transport him. So we're on scene for 10 minutes or until we get a pulse. So after 10 minutes, we're like, all right, we're going to try and take him to the hospital now. But we've done everything. There's really for trauma, there's a golden hour. For cardiac arrest, there's really a golden 10 minutes. That's not an official rule. That's my rule. You have a 10-minute rule to get someone back from a cardiac arrest. After that, it's possible, unlikely. So telling them this is why we're giving the epinephrine, we're getting the airway to suction out his lungs, we're controlling the scene, we're getting him the optimal care that he's going to receive to give him the best chance to live. And having them see that and see their breathing change, Their eyes change, the mentality change, that, okay, we got a pulse, gonna load in the hospital, we're going to this hospital. They're very, very different. And they'll sometimes drive with the family because they're probably not in any condition to drive anywhere. So you take them and they drive with them to the hospital, and not more times than not, but a significant percentage of time, the child comes back. And there's other options now that are also available, like ECMO, which can be, VV ECMO, because it's usually a pulmonary issue, not really an arterial problem. So that VV ECMO is something we're looking at expanding out as well.
So looking at, so there'll be hopefully people listening to this, and indeed systems and services listening to this, that maybe are considering changing their programs or indeed their approach to pediatric cardiac arrest. Paul, there is no magic bullet, but could I get you to speak to some top of mind system changes and mindset shifts that you would advocate really to see these figures and see these successes?
I think first thing is to simplify everything you do. The more intelligent we try to be, the more complicated we become. And the more complicated we become, the more confused people are. So find a way or find a system that that you can just wake up in the middle of the night. How are you going to respond at 3 a.m? If you can respond at 3 a.m the same way you do at 3 p.m, your system's right. So choose a system that is simple. That's a system one system thinking. Number two, every rhythm is different. PEA is different than VFib. PEA has 12 different causes. It's unlikely it's an MI or a tension pneumothorax or a pulmonary embolism in a child, possible, unlikely. But all the other ones, acidosis, hypovolemia, hyperglycemia, all these things that are there, are we addressing them? Is it an overdose? We don't know, right? Is it hyperkalemia? We don't know. So let's not try to be scientific. Throw everything, if it's a PEA bundle, to get that person back, which is actually in adults, our survival rate's 18% for PEA arrest, which is unheard of. So we're doing the same thing with adults. So you've got the PEA and you've got the VFib, right? Initially, start with what's the first thing you do? They'll call 911. Let me change the dispatch matrix. If I've changed the dispatch matrix, I'll need all the information. Just tell me how old they are. Once I know how old they are, I can drop the meds. I'm ready to go on scene. I know to push all the meds I have. There's no thought required. System one thinking. You work them on scene because working in the back of the ambulance while there's moving at 60, 70 miles an hour while you're trying to do compressions is not going to be very good or effective. If we can do mechanical CPR, even better. But in a controlled environment, out on the scene like you would an adult, and we do the same with adults as we do children, 10 minutes on scene or until we get a pulse. Then after that, we've done the airway. We've done at least 3 to 4 rounds of medications and chest compressions. We have basically controlled the environment, controlled the temperature, which is another issue. So if they're in a pool, they're cold, we made them warm because you're not dead till you're warm and dead. So we've controlled all the factors we can to give the optimal chance of survival. Now we've gotten the airway. What do I do post-ROS? Because I want the brain to be living. So I've done all the things everybody else says, all the things that AHA says to that point. But what it doesn't address is what happens after you get your result, right? And no system, ASHI, AHA, doesn't mention, what do I do post-ROSC? ROSC is like the goal. Well, ROSC really isn't the goal. ROSC is an intermediate goal. The goal is to have them walk out of the hospital alive. That's what I'm trying to do. So if I've got a ROSC, now how do I optimize that ROSC to get the best outcomes? That's regulated through end-tidal CO2. It's regulated through blood pressure control in the brain. We're happy with a pulse, but if they have a pulse and they're not perfusing the brain, what are the outcomes going to be? Poor. So how do I make sure the blood pressure is systemically high enough that the brain's being perfused, the oxygenation is sufficient that the brain's being perfused, that I can have some neurologically intact survival? So it's basically the whole game.
Listen, that's fantastic. Absolutely fantastic. So, Paul, just as we finish off, could I just ask you around post-incident debriefing on pediatric cardiac arrest? Because there is a lot to learn from debriefing and, looking at the successes and indeed the challenges on scene. Do you instigate post-incident debrief on these types of calls?
Every cardiac arrest is offered a debriefing. I think obviously if it goes well, people don't need a debriefing. If it goes appropriate, they don't need a debriefing. If it goes sideways, then they need a debriefing. And I think a lot of it is now, you have to understand, we don't do this very well or very much in the pre-hospital setting. They do it even less in the hospital setting. Now, if you're in a pediatric hospital, specialty pediatric hospital, then they probably do it a lot more than most everybody else does. But how many pediatric specific hospitals are we transporting to? It's very, very few. There's probably one in every city, maybe. And I don't know for England. I used to grow up there, but I don't know but now. But I know like maybe in the big cities they have one pediatric hospital, not everywhere. So if you're not near that pediatric hospital, what do you do? Because you know that the community ER physician doesn't deal with this every day, isn't very good at this. And if you look at termination of resuscitation, and that's the one caveat too, is we don't terminate resuscitation in the field because of a couple of things. A lot of studies have shown even they get a ROSC and a pulse back after 16 to 20 minutes. We go by two caveats. If your end tidal CO2 is less than 10 for 20 minutes, the person's probably not going to make it, but we transport anyway, they can become an organ donor. If it stays greater than 20 end tidal CO2 for more than 20 minutes, there's a chance that person's going to live. That may be a candidate for ECMO, but over 20 means something good is happening. Unfortunately, when you take it to a lot of the community hospitals, which is probably 90% of our hospitals, what they usually do is they do 2 or 3 rounds, said, well, I think they're dead. Let's call it. Everybody okay with it? Because they don't understand what end tidal CO2 does and don't understand what it means and what it shows you and tells what story it's telling you. And I see a lot of this place. I've taught at a lot of places, and they're like, when do you call resuscitation? Well, after 2, 3 rounds, and if nothing else is going on, we'll just call it. Like, what about end tidal CO2? We don't care about that. It's probably unlikely after 3 times that they're not going to come back. But if your end tidal is 50, that there's something going on. But I don't think hospital physicians understand that like paramedics do. So when it comes to the field of resuscitation, I think a paramedic would do a much better job than a doctor.
Yeah, indeed, absolutely. And to your point around, just looking at these metrics like ETCO2 as cardiac output, as a surrogate marker for cardiac output, and understanding that there is a whole suite really of metrics to appreciate, but cardiac, but end tidal CO2 is absolutely fundamental in that. Listen, Paul, thank you so much. What we're going to do in the show notes is really signpost to your resources on YouTube, because you've some fantastic resources on YouTube, and I just really I really want to just thank you for your time, but also just for the mindset shift. And it's fantastic just to see the results you're getting as a result of that. So thank you so much.
Thank you so much for having me.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.